Good morning. I'll be talking about an approach to cognitive neurology. And a lot of you will know that I'm going to be talking about higher mental functions. And higher mental functions, as an MBBS student through my postgrad days, was the most confusing and flummoxing thing. If you get a patient with higher mental functions, you know that you're in a quagmire and you're going to probably fail the exam. So it's always important to have an approach. And one of the reasons we never really had an approach to higher mental functions was there was no overarching theory of brain function that we could use at the bedside. So what I'm going to present to you is a simple theory of bedside cognition, or a model of brain function that you can use for bedside diagnosis. So I'll take you through this journey. So this is probably a question, rhetorical question. Is it a plant or an animal? If anybody wants to answer, you can answer. If not, it looks like a plant, but it's actually an animal. And what's interesting about it is that it's a sea squirt and it's got a life. Uh, its larval stage looks like a tadpole, moves around. It's got eyes and a brain. And as it settles down in life, it's like most of us, it stops using its brain and it just gets food from above, and the brain gets auto digested. So this organism is important because it tells you that the most important thing, purpose of the brain is locomotion. So if you're having locomotion as an animal, then you need to have a brain. So if you have to have locomotion, you can't just move around in space. You need to also have perception. And this brings to another theory called the free energy principle, which says that anything that exists over time has to kind of avoid surprise. So to avoid surprise, you need to have both perception and action. So if you have to look at entire brain function, it can be divided into two things. One is called perception and action. So any organism interacts with the world using this perception action cycle, and it tries to survive, and that is the summary of all brain function. So you complicate it with billions of years of evolution and you have the human brain. And how is it really useful in terms of neuroanatomy? So if you look at the central sulcus is here. You can see that that divides the brain to the front of the brain and the back of the brain. And if you look at it, everything back of the brain is for perception and everything in front of the brain is for action. So if you don't believe me, you can see that Broca's area is sitting in the frontal, Wernicke's area is in the back, occipital cortex is in the back, frontal lobe is in the front, that decides action. So it's a very useful theory. And if you look, you can complicate it even at various levels. You can see that there is always this kind of perception action interaction that goes on. So the entire brain can be seen as a perception action cycle. So coming to the next level, starting from the brain, there are certain brains are made up of neurons. Neurons are connected to one another and they are called as networks. And there are various kinds of connections, one-to-one connections and one-to-many connections and many-to-many connections. So one-to-one connections are like serial electrical connections. If you damage one, everything goes below that. Classically, is the corticospinal tract, spinal cord. So classic stroke-like diseases that you damage one area, everything goes below that. One to many is like the brainstem. If you damage one area, the entire level of consciousness drops. And many to many is like the association cortices. That they are like parallel connections. You can remove large areas of frontal lobe and temporal lobe, and patient may not have any deficit at all because there are many to many connections. So using this knowledge, I want to define two functions. One is called channel function, the other is called state function. Channel functions are one-to-one connections. That's what's happening within the brain. And state functions is like the brainstem and the arousal system. And I want you to use a metaphor of an umbrella. I'll come to that. So there are state functions and channel functions. And if you use the metaphor of the umbrella has got a kind of a opening mechanism and canopy over here, and there is this kind of the handle. The handle is like, and the opening mechanism is like the brainstem, and the canopy is like the cortical areas. So state function is the brainstem, and channel functions are various brain areas talking to each other. So if you have to really say whether your umbrella has got a hole in it, you have to be able to open it. So you really can't comment on channel function, that is aphasia, apraxia, agnosia, and memory, only if your arousal and awareness is all right. So that's an important thing in approach to cognitive neurology. So I told you the entire back of the brain is for perception, everything in front is action, and at the base is the brainstem is arousal. Once arousal is normal, what you will actually need to do when you perceive things in the environment is where, what, who, and when. And action is to do, which is motivation, that is wanting to do, how to do and what not to do. So the entire brain function can be summarized like this, and this can be a very useful bedside theory. So, and so now if I say that there's an apple on the table and I want to see it, the information goes to the retina and goes to the occipital cortex. Then the pathway then it divides into two. One goes down and one goes up. The one goes down is the what pathway. So that goes to shapes, colors, finally comes to the anterior part of the temporal lobe, compares it with my memory in the hippocampus and says, that looks like an apple. So that is called as the what pathway. Similarly, the same information goes to the parietal lobe through what is called as the dorsal pathway. And the parietal lobe has a concept of space, concept of view, concept of where your hand is, and says, that looks like an apple and maybe I can reach it if I want to. And again, another important thing about cognitive function is attention. Attention is like the frontal and parietal lobes are constantly talking to each other along with the thalamus. And that acts like a spotlight saying which aspect of the complex world that you need to pay attention to. And once your attention falls on the apple and you say that apple is on the table, you can decide whether if you're hungry, whether you really want to do something about it, ignore it, or to move towards the apple. So either you can either approach or not be distracted by it or not really do anything to it. And how to do it and what you do it. So I want to get up and go pick up the apple. That means I need to plan my action. I need to break down it into multiple steps, go and pick it up and come back. So that is actually called as goal-directed behavior is called as executive function. That is nothing but a simple word to describe it is how to do something. What not to do is inhibitory behavior. So if I find an apple and it's not appropriate that I pick it up and throw it up on all of you, and that the social cognition and the inhibition is from the orbitofrontal cortex. So if you look at the frontal lobe, there are only three parts: medial, lateral, and inferior. The medial part tells you wanting to do, the lateral part tells you how to do it, and the inferior part tells you what not to do. So again, I'll quickly run through some of these things that I already covered. This is just to say that that theory is enough to explain complex different visual areas. You see all the visual areas can be divided into the dorsal and the ventral pathway. When it comes to parietal lobe, the additional information that you need to know is the left parietal controls hand movements, while the right parietal controls space and visual exploration. So if you have problem with left parietal lobe, you'll have apraxia and difficulty in using the hand. But if you have problem with the right parietal lobe, you'll have problems with visual search, neglect, and negotiating the environment. Coming to the temporal lobe, another useful thing to know is that you can divide temporal lobe into medial part and the lateral part. Medial part is for memory, while the lateral part is for language. Left side is for linguistic aspects of language. Right side is for the emotive aspects of language. Frontal lobe, I already said that it can be medial part, lateral, and inferior. Medial is for motivation and mood. Lateral is for executive function, which is goal-directed behavior. And inferior is for preventing or inhibitive response. So finally, applying this, this slide is actually like a take-home point. So you can use this to come to symptoms. The commonest cognitive neurology syndrome that you will come across is progressive cognitive impairment. And the symptom that we used to localize is the first symptom that the patient develops and gradually worsens over time. Suppose a patient comes to you with a 60-year-old man comes with progressive memory impairment. He's forgetting names of people, forgetting where he's kept things, but all other cognitive functions are normal and it evolves over more than 2 years, then you would suspect that he's got a problem with memory. And easy way to remember that the temporal lobe is involved in memory, the medial aspect of temporal lobe is involved in memory. And as you can see here, that verbal memory is in the left side and visual memory is on the right side. So patients who come to you with both, you would think that bilateral medial temporal lobe involvement. He's got symptoms that evolve over more than 2 years. So you would think of cognitive, major neurocognitive impairment. And in this case, this is a classical presentation of Alzheimer's disease. Suppose, let's imagine there's a 50-year-old man who comes to you with disinhibited behaviors, misbehaving at workplace, has had the run-in with the police, also is forgetting things, is found wandering, then you'll say that he's got problem with probably behavior. And behavior is generally localized to the frontal lobe. He's got problems with executive function and also with disinhibition. You'll say that both the orbitofrontal cortex and the dorsolateral prefrontal cortex is involved. Insidious onset, gradually progressive. So you'll think of something like a frontotemporal dementia. So that would be a general approach. And this simple slide can actually help you localize most of your cognitive symptoms. Coming to what is the latest in neurodegeneration, a lot of these disorders are degenerative. All we know is that the brain shrinks over time, and which may or may not be associated with cognitive impairment. And generally, there are genetic disorders, plus they're all proteinopathies, they're multifactorial in origin. And you'll find the common thing is that there is some abnormal protein that is deposited. Very often it's tau, which is a common pathology, both in Alzheimer's and other degenerative conditions. And this causes neuronal damage. And there has been a lot of therapies trying to target this kind of neurodegeneration. If you look at pathophysiology of Alzheimer's disease, one of the current hypotheses is that it has something to do with amyloid. So these amyloid beta uh, pleated structures are formed this in turn starts off tau to get deposited in the brain. And also there's inflammation and other contributing factors. And in terms of therapy, people have tried various things. And one of the most uh, close to successful things is trying to deplete amyloid. And another important thing when it comes to Alzheimer's disease, which is new, is the classification of Alzheimer's itself. Uh, what is new is called as ATN, where A stands for amyloid, T is for tau, and N is for neurodegeneration. Because we have amyloid PET, which can actually pick up asymptomatic people who have amyloid. So you can actually classify people whether they have the pathology or not, whether they have amyloid, whether they have tau. So amyloid means that amyloid deposit is there. Tau means that they have the pathology, and neurodegenerative means that they have disease. So this is important because as we go into newer therapies, we may need to catch patients earlier on into therapy to give them any treatment. And there are also a lot of new PET biomarkers that are coming up, which may be useful in early diagnosis. So if you come to treatment, there are two new drugs that are being approved. There are a lot of controversy still about it. The general thing is that if you take patients with mild dementia, that means they have some impairment in work-related activities, but their basic activities of daily living are not affected. They can be recruited for these kind of treatments. And you'll find that there are a lot of adverse effects, mainly related to hemorrhage and edema of the brain because of damage to the vasculature. And very often there are case reports where patients treated with these have large intracranial hemorrhages, especially when they're used along with anticoagulation. So we need to still be cautious, as these drugs may soon be available here, and we may need to be cautious in including patients because a lot of our patients have comorbidities and may not be very clear cut having a single pathology. A little bit on what we're doing for the last few years in neurology in CMC is that we've started a basic science cognitive neuroscience lab. And I'll tell you how we've been able to improve patient care and contribute to clinical diagnostics. In this lab, what we do is we test behavior by using game-like things. These are called as behavioral tasks. And they're very often kind of culturally adapted. So it's like a game here. You can see that there's a Telugu task where we look for the emotion of these two, Motu and Patlu there. So the participant has to guess the emotion. So depending on the context, we have a whole battery of tests uh, using which we can actually assess all the brain function that we talked about. We also look at EEG data, and we are able to couple behavioral data with EEG data and identify novel event-related potentials. And these can be used as novel biomarkers for diagnosis as well as therapy. The other thing that we do is we look at lesion location and try to associate it with brain function. So what we do is take patients with focal brain lesions, do a lot of bedside assessments and behavioral testing on them, look at the damaged area on the brain. Then we put it onto an atlas, and we do statistical analysis associating the behavior with the damaged part of the brain. We use this by using simple statistics. We also use machine learning algorithms and also work with fMRI data and DTI data set. So using this, we've been able to kind of map classical things like the homunculus. Homunculus, Penfield actually demonstrated using microstimulation. These are data from stroke patients. We were able to similarly map the homunculus. We also identified the brain areas associated with consciousness from our own stroke patients. We were able to identify the reading network and come up with classification of reading disorders, which can be used as a bedside kit to make diagnosis of reading disorders. We were able to identify new disease conditions as well, just by studying single patients and identifying brain areas for motion processing. We also try to tackle big challenges. There is no clinically robust way to test cognitive function in patient. And so we decided to do this by coming up with what is called as the Vellore cognitive assessment tool, which is called as VCog. So this is what we've been using for almost a year now. So it's a computer-based assay, which is probably better than MOCA and easier to do in the Indian cultural setting. So here we do a simple task for attention. There's a flashing block, and then there's naming and registration. There's a maze task to study decision making. We study emotion recognition with the standard batteries, don't test. And then we check motor responses, and we assess theory of mind, which is not done in most of the other tasks. At the end of it, we get a nice report like this, which tells you domain wise, and the total score is 42. And we also give kind of a nominal thing saying whether it's impaired or not. As a clinician, you can just look at it and say which domain is gone, and you can send the patient to the therapist. and the therapist will focus on that particular thing for rehabilitation. So we compared it. Initially, we had a discovery cohort of close to 500 patients, a validation cohort of 1,000 patients, and we established now cutoffs for dementia, which is 29, and for MCI, which is 29 to 35. And we find that this is a very useful tool, and we encourage everyone in the hospital to kind of order these tests to find out whether your patients have any cognitive impairment or not. And take home message, this is a simple theory for brain function, which you can use at the bedside. And thank you for your time.
Thank you, Dr. Prabhakar, for that very, very interesting talk. I'll just go on to the next speaker, please.
I would like to invite Dr.